moderators and dear audience. My due is to talk to you all about what are the discrepancies which you should look for when you're doing an optical biometer reading and how you circumvent some of those issues. Basically, we know that we have the best of IOL designs, the best of IOL power calculations, the best of formulae which we have, biometry too. So now the success in a surgery is whether you are within plus minus 0.5 diopter of the target emmetropia. And actually, if we realize that if we are not, then if we accept it as a failure, that is when we are going to be geared to give this kind of success to our patients. Biometry is actually just a simple arithmetic with measurements and assumptions. So essentially, when you feed in your post-op target refraction which you want, the issues which are asked for is the axial length, the K and the effective lens position. Now we are at an unsurpassed accuracy as far as our axial length measurement is concerned, but the corneal power continues to be a challenge because especially in those post-refractive surgery or eyes which have been surgically treated and more so, and effective lens position is again a huge challenge which I would be discuss with you all as we move on. So these are the challenges which finally is going to help you come to a IOL power calculation. So we realize that some are accurate, some are some assumptions, which is where the discrepancy comes. You could be lucky to have a post-op refraction of 6.6 both eyes, but you could also have this. So does it mean that a post-op refraction of 6.6 both eyes, is it that one error on the one particular reading cancelled out the other, or is it they were just too perfect a measurement? But there may be a time when you will have a refractive surprise, and that is when it makes you want to go back and understand how to do it better. This what all I told you already was also discussed by Norby et al. In 2008. So then what was further analyzed in this particular graph was that if you use the third generation formula, you may do well in majority of the situations. But in those extremes of axial length and in these post-surgically treated eyes, you need those latest generation formulas to get you that kind of end result which you want. This was another study again where they compared the Hill RBF with the EVO and the Barrett's, and it again reiterated the fact that when you're using these formulas, you're well within 92% of the time you're within plus minus 0.5 diopter. So what do we do? I'm keep throwing so many options to you. Does it mean you keep typing in multiple formula and then decide which is the most accurate measurement? Or you look at your results and choose which is the best and stick to that for your own by analyzing some 100 eyes. So it is most important that we consider these pearls. We should measure both eyes in all patients. Now this was a patient who had a PSC cataract and it was done on immersion biometer, and the axial length, that exclamation mark is there. And you also see that the IOL power in the right and the left eye is quite different. So then immediately you should go and repeat your immersion biometry measurements. You remove all those outliers, take those eyes which are going to be average, and then you get your final accurate answer. But incidentally, of course, you need to see whether the spikes are of equal amplitude, the gain is low. You should see that the standard deviation is less than 0.06. You need to be very accurate. And incidentally, we repeated the optical biometer in the next day, and it was 22 in both eyes. But then the immersion also said it was 22, and then you are convinced to go about it. You should always measure, even if the other eye is a pseudophakic eye, you should look at that eye also, because it gives you information about the axial length, the corneal power. So if there is some asymmetry in these situations, you need to repeat your reading and cross-check. You should remember that if there is a difference in the axial length between two eyes of more than 0.3, if the K between the two eyes differs by more than 1 diopter, and if the IOL power between the two eyes differs more than 1 diopter, you need to be repeating your measurements. You need to look at the raw data. On the optical biometer, you should look at those LED points. Does it have a fishtail appearance? Now this was a patient who had a 0.5 diopter in one eye and 2.6 diopters of astigmatism in the other eye. But when we looked at him in the slit lamp, we found there was so much of SPKs and filaments. So after treating the dry eye, when you evaluated him, it was actually 0.2 in both eyes. So if there is dry eye, we need to repeat our measurements. We need to see whether the signal to noise ratio is more than 2. We should see whether the standard deviation in your readings is less than 0.2 or 30 microns. Especially in a normal eye, you will find that if it is in the normal range of axial length and anterior chamber depth, you would find that you could use any formula and you are doing very well. But in long eyes, now this is a highly myopic eye, there is a difference in the IOL power in the different readings, but these are 2 and 4. So the effect of the refractive surprise, the outcome will not be so hampered. But if you're looking at a short eye, wherein the IOL powers are 48, 52, and there is a difference in the values of 2 eyes, you have to become even more cautious, because a small change in your IOL power can bring a big refractive surprise. Again, in post-laser vision correction, multiple studies have told that when you do your IOL power calculations, you are better in myopic eyes, myopic LASIK eyes, less than PRK, then comes hyperopic LASIK. And in all these situations, you find if you're using your Barrett TrueK TK, you are actually doing good. There are certain additional measurements. All I've been talking about, 70% of the cases you are going to be doing well. In those 30% of cases when there is a challenge, when you see that your standard deviation in your readings is different, it is more than 30 micron, more than 0.2 diopters, look for dry eye. The dry eye is not there, don't give up. There's some discrepancy, rule out whether there was a refractive surgery done, is there an early KC, is there a PMD, do a tomography, use a toric IOL power calculation, do everything to get the right result. You might have done everything perfectly, but let's understand that you would have planned where the IOL sits in the bag, you would have used the best formulae, but the effective lens position, that is where the lens sits in the eye, which is the distance from the back of the cornea to the implant center, that can change even in the post-operative period. It is said that the anterior chamber depth shifts from more than 1 millimeter shift can occur between 1 hour to 2 months. So then you think you have hit the nail, but then you are not there. So probably the future is wherein you would find that you have a technology which will do post-operative corrections, which would probably have something, adjustable facility which would come in. Maybe when you would say that all your patients, you planned a target emmetropia and you ended up with target emmetropia. Thank you very much.